So today we'll discuss an MR brain of a female who came with headache and eventually got an MR with contrast and spectroscopy done. We initially start with the T2 weighted images in this particular case, and we see that there is a solid lesion which is iso to hypo intense on uh, T2 weighted images with central areas of hyperintensity and peripheral areas of high signal also. And this lesion is in the periphery of the left frontal lobe at the region of the frontoparietal junction. And then apart from that, we don't see much of anything except that this lesion is causing mass effect on the adjacent sulci and gyri. We go then to the T1 flare images, which shows some institutes take T1, some take T1 flare. Either way, it shows an iso intense lesion with central area of hypointensity, and we don't see anything else on the T1 weighted images. And then we go to the GRE, which shows no areas of blooming, which means there is no hemorrhage or calcification in this lesion. And then we go to coronal T2 weighted images, which demonstrates the lesion again with perilesional edema and mass effect on adjacent sulci and gyri. And then we go to the next set of images, which is the sagittal images. And the sagittal are T2 weighted images. We look the cingulate gyri. Well, there is some focal indentation, but doesn't look much of anything here. There is a near empty or empty cella seen here. Empty cellas can be incidental findings, can also be seen with increased intracranial pressure. But we don't see any other signs of intracranial pressure like flattening of the globe or prominence of the Meckel's cave or any tentorial herniation or prominence of the sinuses. Then we go to flare images, which demonstrate again the iso-intense lesion with perilesional edema surrounding it. Then we take the contrast images, and on contrast images we can see that the walls of this lesion is enhancing and is thick, irregular, nodular with central area of non-enhancement, the necrotic area. Now this can be thought of as an abscess or like high-grade malignancy with central necrosis. I do agree, but an abscess might or might not have fever. And in this lady, in this old lady, this differential was was thought of, and so we did an MR spectroscopy. But before we go to MR spectroscopy, we will see the rest of the images, and we see that there is again on the coronal images we see the enhancing peripherally enhancing lesion, and then on the diffusion weighted images along with the corresponding ADC maps, we can see whether it's showing restricted diffusion or not. And so on these images, we see that the lesion shows the wall of the lesion shows restricted diffusion. However, the perilesional region where the perilesional edema shows facilitated diffusion. What does that mean? So restricted diffusion means it is showing a high signal with a corresponding low signal on ADC maps, high signal on diffusion weighted images with corresponding low signal on ADC maps, whereas facilitated diffusion is when it is showing low signal on diffusion with corresponding high signal on ADC maps. Apart from that, these were the most of the images, and I would now like to show you the MR spectroscopy of this patient. So the MR spectroscopy was done, and we can see this is a multivoxel. There are multiple voxels here. So this is a multivoxel spectroscopy, and this is the correct way of putting the spectroscopy voxels, where you not only put in the center of the lesion, but also the periphery of the lesion, and some amount of normal brain parenchyma should be included in the voxel study. And then we see that there is reduced Na, which means brain that area has loss of neuronal loss, and there is increased choline and creatinine. But we also see there's an increased lipid lactate peak. So this shows that there is something infective also going on in the center of the lesion. So based on these images, we describe this in our report as an irregular lesion, solitary in the left frontal cortex, subcortical white matter with perilesional edema. Central necrosis is seen. The lesion measures this many centimeters. It is peripherally enhancing on post-contrast study. The solid component, which is the peripheral component, shows restricted diffusion. There is no blooming seen on the GRE images. It appears heterogeneously hypointense on T1 and heterogeneously hyperintense on T2 weighted images. Mass effect is seen on adjacent central spaces. There is no meningeal enhancement. The rest of the report looks normal. And on MR spectroscopy, remember, MR spectroscopy is always a correlative study. It's never a single diagnostic study on its own. It has to be correlated with the rest of the MR. So MR spectroscopy shows significant elevated choline peak with reduction in Na peak in most of the areas. Maximum choline to Na is 3.36. Choline to creatinine ratio is 1.49. These findings are consistent with neoplasm. If you see the literature, you will find that these peaks, these values are more in favor of neoplasm than abscess. But there is a lipid lactate peak also, which suggests there is a necrotic abscess in the center also. So the final impression will be irregular lesion in left frontal cortex, subcortical white matter with central necrosis and perilesional edema, suggestive of a neoplastic lesion, likely a high-grade glioma. MR spectroscopy findings are correlating for necrotic neoplasm, needs histopathological correlation, and the histopathological correlation did come out to be a high-grade glioma. So that is how we are supposed to report an MR brain with contrast and spectroscopy for a high-grade neoplasm. Thank you.